So yeah, thank you Dimitar, and thanks everyone turning up on a Saturday morning when there's usually so much else to do, but that was fantastic. Thank you very much for that last talk. That was saved me a lot of work, because I thought, am I going to have to put in endotypes and things to talk about what immunology does in asthma? But I actually thought, Dimitar showed me the list and I saw who'd be speaking first, and I thought, I'm not going to cover all that fancy stuff. I'm going to go with more nuts and bolts sort of immunology. But it was great to see Paul Ehrlich turn up in a talk. I had to use him in a quiz recently, and I found a picture of him on the internet, and I did compare his very messy desk. If you go to Google Images, look at Paul Ehrlich and his messy desk. Looks like Jeff Bowden's desk. So genius comes with a messy desk. So what is immunology? I guess that's the big question. Everyone's got their own idea. People, do anything with an antibody or a molecule and they call themselves an immunologist, but when it comes to seeing patients, I think different things. I think allergy, particularly IgE mediated, autoimmunity and immunodeficiency. And then in the immunology laboratory, I didn't list all the various things they do because a lot of it's automated anyway, just looking for IgE and antibodies and immunohistochemistry on slides. So the talk was about severe asthma, so not the average asthma, that which is uncontrolled despite standard therapies, inhaled corticosteroids, long-acting beta-agonist, leukotriene modifiers, theophylline, purinergic blockers also there as well. And in the immunology clinic, it comes referred in many ways, especially from primary care. Some people call it brittle asthma, chronic cough, just labelled allergies. And for us, that gives us a chance to review what's actually going on. Is it actually just to review the diagnosis, what treatments people have had, both past, present, and their compliance, what investigations they may have had in the past, and any triggers that they've identified. Because as you say, asthma is one word for a whole lot of different problems, I suspect, or it is. So what we can do, well, we can skin test and see if they're atopic or not. Very interesting. Look for specific IgE that may explain triggers. As I say, half the world will have a positive skin test, so having a positive test doesn't give someone a problem. The patient has the problem, you either can explain it by the trigger or not. You might suggest alternative diagnoses, look for concurrent atopic or non-atopic diseases that they've got. So, if someone's got asthma, they might also have eczema that's driving them even more crazy. Or non-atopic disease, look up the nose, look for polyps and other associated things, and then treat them. So if atopic and severe asthma, and you're convinced that it's in your own head that they've got the sort of problem that might respond to an anti-IgE therapy, you might go for omalizumab. If they're non-atopic, you may consider all kinds of other possibilities. As I say, allergy is almost easier because you know what you're dealing with, whereas with non-atopic or non-allergic things, it could be unidentifiable things. And even when you see people who are atopic, you may still get the impression that what's actually going on up their nose or in their lungs isn't in fact due to IgE at all anyway. So you sort of listen to the patient to get that feeling, or they might have mixed disease. So if they've got concurrent allergic rhinitis, and I know it was at this sort of forum last year I had to debate Bob Heddle about whether immunotherapy works for asthma, and indeed it does. The Cochrane review proved it. The benefit though was the equivalent of using Pulmicort 400 micrograms a day, twice a day. So not exactly humongous. And also with immunotherapy, I think I left this part out of my part of the debate, that there's more risk of anaphylaxis or even death in the most severe cases of asthma. So, and again, they're rare, and certainly newer ways of doing it tend to save us from that, but it's always in the back of your mind whenever you're injecting someone who's severe asthmatic. Having said that, if someone's got asthma and allergic rhinitis and you give them immunotherapy, they do like you a bit more because it does help their asthma more. So I think it's about picking your people as well, your phenotype, your endotype, and that's what we've never been able to do before, and I think that new era is going to really help not just with the biologicals but with other things we're doing as well. So if they're non-atopic, okay, we've had plenty of people turn up with asthma who've actually had bronchiectasis. You've got to think about ABPA as well. aspiration. I know a patient of mine who had he's got mild bronchiectasis, but his asthma was getting worse and worse. Already on Nexium 40 milligrams a day, couldn't get him better. Dimitar had a look down and saw the acid burns in his trachea. So this guy was still aspirating acid despite being on very good proton pump inhibition, and he was fixed with a fundoplication. Paradoxical vocal cord movement disorder. It's pseudo-asthma, presents like asthma. It's a scourge, kind of, because it's so hard to treat, and like pseudo-seizures, occur most commonly in people with real seizures. Pseudo-asthma, a lot commonly in people with real asthma, so it's hard to pick what's what. I think that breath machine is going to be really good. One of my most satisfying things ever was a lady coming in with acute asthma after walking past the bulldozers at Flinders and giving her a nebulizer of saline, which relieved her really quickly. And then getting the pheno machine, and I think she had 3 parts per billion or something of pheno in there. Whereas you get your real asthmatic in and you're getting up to 60, 70, 100. And recurrent infection or immunodeficiency. So another case came to mind when I was getting this talk together, a lady who kept presenting with acute asthmatic episodes, but actually she was sort of febrile beforehand and was making a bit of sputum, and when we checked her IgG, it was 2.0, which is very, very low. So she was IgG deficient, put on Intragam or some intravenous immunoglobulin, and she hasn't had any more asthma. Another case came to mind, a lady with chronic asthma was the referral, chronic cough was the real problem. The speech pathology / voice clinic had looked down. She had huge lingual tonsils sitting at the back of her throat, and they could see the chunks of apple still in there that would gradually drop in and make her cough. Another lady, again, chronic asthma at work, she was an ICU nurse, and when we finally challenged her, I think it was with a very irritant dose of chlorhexidine under her skin, which didn't actually induce an allergic response in the skin, but she got very symptomatic of her asthma, which was all in her throat, and we gave her an injection to fix that, which was not adrenaline, it was midazolam, and it just solved it. Then you have other weird things going on. Another ICU nurse, chronic asthma, probably worse at work, but other situations. And she had a rash as well, and she didn't sound like she had typical vocal cord trouble. So we had a bit of a chat about what she's exposed to. There's a very common preservative in lots of things. You'll find it in all your fabric softeners and things like that, called methyl isothiazolinone, or MI for short, or Cathon's the other name for it. And she was positive on patch test. And we haven't proven it yet, but the current theory is that this stuff, it's in all your hand washers and everything at work, probably in your Miltons and other things you're using to keep them sterile. It's everywhere, it turns to dust, breathe it in, gradually getting a type 4 reaction. Again, not terrible in itself, but really quite scary with the symptoms that it's bringing on. Another case of a chronic asthma, and for some reason changed over to Symbicort, and she was a paramedic. I don't know if anyone remembers the green uniform affair. It certainly burnt a hole in my soul. It was a sort of mini epidemic of rashes and other vague things that were going on when a new green uniform was introduced to the South Australian Ambulance Service. And being a new consultant at the Royal Adelaide, I saw a few of these and then suddenly, by default, became some sort of expert in it. But when we looked at it, it was probably people with chronic urticaria, just bad luck when you actually look back at it. There was a lot of rash, the weird thing being that no one actually knows what dyes were in that fabric. So it was probably actually a textile dye type 4 reaction that was going on. What to, we don't know, because it was made in Fiji ingredients. Meh, don't know. So, fantastic example of everything. Anyway, this young lady was on Symbicort, and her asthma was getting worse. And so she was patch tested again by Lynn Gordon, our dermatology colleague, and she was positive budesonide. So put her back on, I think, Seretide, and all was good again. So these sorts of strange things happen sometimes. And I think that's Evan down the back, yes. So this might be your lady or a different lady. Asthma, nasal disease, and just feeling dreadful for about a year. And she was heavily atopic, just standard thing. And then the asthma was getting worse. A very clever respiratory physician did an anchor. The PR3 was highly positive. It was Churg-Strauss, or eosinophilic granulomatous polyangiitis. So I'd get used to these new acronyms. Prednisolone methotrexate, that's what we had to offer her, and she's doing quite well. Rituximab later, maybe, for an anchor positive vasculitis, if she's responding to the methotrexate, and that for a couple of years we'll probably see if we can wean it off and see how she goes. So more memorable, again, people with asthma, nasal disease, non-steroidal allergies, brufen in this particular case. You think of Sampter's triad, that then was called aspirin exacerbated respiratory disease, then non-steroidal exacerbated respiratory disease. So that's where all the names are coming from there. And we have a thing where if I'm convinced they've already done the challenges at home and failed enough, we'll just desensitise them. But otherwise we bring them in for what we call a 2-day challenge, whereas if they fail that, there's usually lots of adrenaline involved to get them through part of that. Typically at around the 90 milligram dose, where these people tend to react to the 90 milligrams of aspirin. But then once they're exposed to it and you push through that, you can actually desensitise them. You're flooding what we suspect is actually a COX-1 mediated mechanism. The big question then is how much aspirin and for how long. So these guys end up on 600 milligrams twice a day, which is quite a lot, and they don't necessarily like being on that much, and I don't like them being on that much. And the Americans are gradually getting people down. We're thinking maybe we can get over 200 or 300 milligrams a day. Triggers, mould as a non-allergic trigger has certainly risen. New York epidemiological study that showed atopic versus non-atopic patients with asthma, rhinitis, bronchitis, if they attacked the mould in the house, both groups of people got better. So it's almost like the atopy let you make IgE antibodies that then you could find on a skin test to direct you where to look for the problem. Whereas the non-atopic people, you didn't get that clue. So the big question then is IgE cause or effect in these sorts of cases? Melbourne asthma in kids last year, or a year before it might have been, was flaring 48 hours after peak mould spore levels were recorded, which is suggesting a delayed mechanism, so not IgE mediated. Half those kids are probably going to be positive, and I think it might have been about a third of them were positive to specific IgE. It's lucky just for them that they make up that specific IgE, the others didn't. How many pollen counters are there in Adelaide? Anyone know? At the moment? That's right, none. And we need about 3. So the Victoria suddenly have 5 being given. I'm not sure why that is. Did someone say thunderstorm? Yeah, so is specific IgE cause or effect? That was my worry there. Other things immunologists like using is Intragam, intravenous immunoglobulin. It's not recommended and there's no great evidence for it in general. And specific antibodies. So we've already heard a bit about the development of these and their targets. That's what I was going to hit as well. Sorry about the ugly slide. I just wanted to show every single TNF, TGF, interleukin, etc., that was going on. But we do think about the different endotypes, the T2 and the T1 over here. So the T2, with your attacking either with binding free IgE with omalizumab, and then you get gradual reduction of the Fc epsilon receptor on the mast cell, and they become less responsive. Less responsive mast cells means less irritation with the histamine, leukotrienes, other things that will bring on asthmatic symptoms. And the IL-5 antibody, anti-IL-5 therapies that bind to interleukin-5 and then sort of down-regulate and get rid of eosinophils in one way or another. So I won't go into that too much just because we're running out of time, but also I think they're well covered before. Oh, I forgot to do my conflicts of interest. So yes, I'm a paid tart for Novartis and omalizumab in chronic spontaneous urticaria, and did some work with CSL Bioplasma on something. So that, just coming back to this again, there we go. So yeah, we heard you can either block IL-5 receptor on the actual eosinophil itself, or the IL-5 and take that out of the loop. So, and yeah, I've been fascinated as well by the if you like, the non-T2 endotypes and what's going to try and fix that. And there's just a little summary there of what these drugs have been found to do. Then, are they lifesavers? Probably not proven. Are they life extenders? Maybe. Do they make people's lives better and stop them having flares? That's where they seem to have their major advantage. Long term, we may see other effects. But yeah, so blocking TNF alpha, we've been doing it for quite some time in other diseases, mainly with infliximab and adalimumab for various diseases, and they are potentially showing some promise. And again, seeing something in tissue or finding it expressed somewhere doesn't always mean that by blocking it you'll bring about an effect. The classic there with the IL-4, IL-9 story was if you block IL-9, you don't have as great an effect as blocking IL-4. And the body's ability for redundancy is amazing. I think we're probably also going to learn a bit more about how omalizumab works. So in chronic urticaria, it'll work within a week, getting rid of urticaria. With asthma, you're taking 3 months, and that's because you presumably it takes that long to remove all the free circulating IgE. Why it works so quickly in chronic urticaria, we have no idea, but it's obviously not the same mechanism. So, conclusions. Clinical immunology, I think, provides us with diagnostic and therapeutic assistance with atopic disorders. I think skilled in recognition of non-atopic diseases in skin prick test positive people, and I think that's where these new gas analyzer endotype defining mechanisms are going to be amazing. Considers important differential diagnoses, so you have the odd win where, hey, it's not asthma, it's something else. It might actually be worse, but that's at least patients know. Try and target biological treatments, as I say, targeting and knowing what phenotypes, endotypes you're attacking is, I think, going to be the major challenge, and that's under development. So I'd like to thank everyone.
Thanks very much. We have 1 or 2 minutes, so just if there are any specific questions, we'll have more time at the end there as well.
I've got a hoon after this one. So.
Oh, that's right. So, Christine, did you have a question?
Sorry, it's about chronic urticaria, completely different, but given that you mentioned that, hi, so I'm a respiratory physician from Melbourne, and I was helping my new allergist triage patients, and I said, oh, look, all these urticarias, they can go off to the dermatologist, and she said, no, we've got omalizumab. So what's the sort of incidence of chronic urticaria? It seemed to be quite prominent in our allergy clinic.
Yeah, I'd probably see 4 or 5 new ones a week. We say 30% of people throughout their lives sometime will have an attack of hives. If they get that for more than 6 weeks, that's then chronic urticaria just by definition. Most people can control it, as I say, at the bus stop. Oh, there's an ad for Zyrtec. That'll fix them. It's got a great spontaneous regression rate. But for people where it just goes on and they can't control symptoms with simple antihistamines, that offers another level of treatment. But often they're looking for an allergen, and it's not an IgE-mediated problem. So that's the talk on Thursday night to the dermatologist was, don't go looking for an allergen, you won't find one. I reckon I might have found one true protein IgE-mediated chronic urticaria in 20 years. So I've given up looking.
So, and just one other quick question. If you do identify a specific response, either house dust mite, animal dandruff or otherwise, apart from getting rid of the cat, are there any other environmental modifications that are actually successful in improving asthma?
Well, as I say, getting mould on top of mould was successful. Like household mould was successful in the American model. I mean, the dust mite story, I just see where they look at clinical outcomes of, say, putting on the covers and doing this, doing that, and they show, yes, there's less dust mite in the, whatever the dust mite capturing little filter paper is, but the FEV1s and symptoms don't improve. So I've never been greatly impressed by all that.
Okay, that's good. We might leave it there. We'll have some time at the end for some further questions. So thanks very much.
Okay, I've got a hoon, so.
That's right. Thank you. And so.